Good evening and welcome you all for the third National Pleural MDT. We are really happy to share with you all of you that the first two national Pleural MDTs were very successful and we had very good discussions among us. And now we are going ahead with the third National Pleural MDT. Today we have three cases which will be presented by three presenters from different parts of the country. The first case will be presented by Dr. Ritin Reddy. He is the second year DNB pulmonary medicine resident from Lilavati Hospital, Mumbai. He is working with Dr. Prabhu Desai sir there. The second case will be presented by Dr. Rishabh Ranjan Singh. He is again a second year DNB resident from Ramkrishna Care Hospital, Raipur. And the third case will be presented by none other than Dr. Pradeep Jain. He is a senior consultant pulmonologist at Chatram Hospital, Indore. Each case will be presented for 5 to 7 minutes, and this will be followed by a panel discussion. Today we have a star-studded panel with us. We have four eminent panelists with us. The first is Dr. Sajal Dey sir. He is the professor and head of the department of pulmonary medicine at AIIMS Raipur. The second panelist is we have Dr. Vishweswaran Balasubramaniam, who is again a very eminent interventional pulmonologist from Yashoda Hospital, Hyderabad. Then we have Dr. Ravi Doshi, the star of today. He is a senior consultant pulmonologist at Kokila Ben Hospital, Indore. And we have none other than Dr. Mohan, the only surgeon in this panel, Dr. Mohan Venkatesh Phule, who is a very eminent known thoracic surgeon from Medanta Hospital, Delhi. Now we'll start with before we start, just to introduce myself, Dr. Sushil Jain. I'm a consultant pulmonologist and head of the department of pulmonology at Ramkrishna Hospital, Raipur. And my colleague, my dear friend, Dr. Richa Gupta, who will be also moderating the session with me today. Now, with this introduction, we'll move on to the first case, which will be presented by Dr. Ritin Reddy from Lilavati Hospital, Mumbai.
A 42-year-old female with no known comorbidities, writer by profession, a resident of Andheri, Mumbai, is an ex-smoker with significant smoking history of 20 pack years and socially consumes alcohol. And is a frequent trekker, has consulted us for the first time in September 2025 after taking multiple opinions elsewhere. She has come with the complaints of recurrent progressive breathlessness since September 2024, which has gotten aggravated over the last month after undergoing certain interventions. The breathlessness is not associated with cough, orthopnea, PND. There is no history of fever, night sweats, significant weight loss. There was no history of skin rash, joint swelling, or any other overt autoimmune symptoms. There was no significant family history and no history of trauma as well. She was apparently all right till April 2024. She was diagnosed with bilateral pleural effusion incidentally when she got admitted for pain, abdomen and diarrhea for the first time in this month. She was given antibiotics and nothing was done about the pleural effusions. Later that year in July 2024, when she was trekking in Spiti Valley, she desaturated to 60% on room air and taken to a local hospital where she was given oxygen therapy and was discharged. No radiology was done at this point. And in September 2024, last year, she was admitted for the first time for progressive breathlessness, and where the evaluation showed bilateral pleural effusions on X-ray. HRCT confirmed the same. There was a partially calcified thyroid nodule as well. Bilateral thoracentesis showed exudative lymphocyte rich effusion, ADA and LDH were not available in that hospital. So gene expert and cytology were inconclusive. The evaluation of the effusions included CBC, CRP, LFT, RFT, lipid profile, thyroid profile, which were all within normal limits. The 2D echo and NT-proBNP was also within normal limits. Triple H was negative. Ultrasound abdomen pelvis, no abnormality detected. And autoimmune workup showed weakly positive ANA with 1 in 100. And ANA blot showed a borderline positive dsDNA. The value was 16. The cutoff here was 15. And RA and anti-CCP were negative. She was managed with diuretics, antibiotics, and discharged on tapering doses of prednisolone to be completed over the next 3 months. Post thoracentesis, she was symptomatically better, and in the month of November 2024, she relocated to Manali. Over there, she developed again the breathlessness, and this time she was admitted to a hospital in Delhi, where they repeated the investigations again. Bilateral thoracentesis at this point yielded right-sided milky turbid fluid, which was suspicious for chylothorax, and triglycerides and chylomicrons were sent, which turned out to be positive, with the triglyceride levels being 211. ADA and ADA was low. The left side fluid was not sent for any chylothorax evaluation. It was looking serious. Again, the microbiology and cytology were inconclusive. So chylothorax was investigated with lymphangiography, which showed bilateral patchy opacification at the level of iliac lymph nodes, and the dye did not ascend beyond this level. Ultrasound abdomen pelvis did not show any ascites. Again, the autoimmune profile was repeated. Here, the anti-dsDNA came out to be positive 26. Mind you, the cutoff was 15. After consulting the rheumatologist, they suspected SLE and treated her. Started her on tapering courses of steroids along with mycophenolate mofetil, HCQ, and medium chain fatty acid diet. Post thoracentesis, she was symptomatically better and was discharged. For a few months, she was okay. Again developed progressive breathlessness despite being on these immunomodulator therapy. In the month of July 2025, she got admitted in the same hospital in Delhi for these symptoms. Again, the repeat tapping showed persistent right-sided chylothorax and left-sided exudative lymphocytic effusion. The anti-dsDNA at this point was 21. She was on immunomodulator therapy. They did a PET CT scan to evaluate the effusions, and it did not show any evidence of lymphoma or metastatic disease. There was no parenchymal uptake as well. There was bilateral moderate bilateral pleural effusions, and there was a hypodense nodule in the left lobe of thyroid, which was evaluated with FNAC and turned out to be a benign lesion. After this, the patient moved back to Mumbai and then consulted multiple rheumatologists and pulmonologists as well. Finally, she stopped the immunomodulators. In the month of August 2025 this year, she got admitted in a hospital in Mumbai for further management. A repeat lymphangiography was attempted, which was unsuccessful. She was told that the dye did not, her lymphatics were too thin to delineate, and the dye did not ascend properly. Eventually, she underwent right-sided wax-guided thoracic duct clipping at 2 levels. In the same sitting, she also they also took multiple punch biopsies from the pleura of the left side, which showed fibrofatty tissue with lymphocytes. Again, the microbiology is negative, gene expert negative, culture did not grow anything. While being admitted here, there was persistent drainage of the chylous fluid through the right ICD. Eventually, they did thoracic duct embolization on 6th postoperative day, and patient was discharged. 1 month after the discharge, patient again became breathless, and this is when she has seen us in our OPD. At the time of presentation, this is her chest X-ray with bilateral pleural effusions, right-sided loculated, and there is evidence of surgical intervention. And so we asked the patient to strictly follow the medium chain fatty acid diet, and then repeated a chest X-ray which showed increase in the effusions. So we had to tap the effusions to see whether it is still persistently whether it is chylous again, but it turned out to be bilateral exudative lymphocytic with no triglycerides on both sides. So eventually we started her on ATT. Currently The summary is of she's a 42-year-old female ex-smoker trekker with no comorbidities, recurrent bilateral lymphocytic exudative pleural effusion, received antibiotics, diuretics, steroids, immunomodulators for suspected SLE, right-sided chylothorax was evaluated, underwent right thoracic ligation at 2 levels, and eventually thoracic duct embolization was done. Despite this, there is persistent effusions and exudative and lymphocytic in nature, and this is her current X-ray after the start of ATT.
Thank you, Dr. Ritin. Interesting. A very difficult, complicated case, and a food for thought for all of us, how we will move ahead from here. So now we start with our panel discussion.
One sec, sir. Nitin, can you stop sharing the screen, please? Yeah, that's better.
So we start with a panel discussion on this case. I'll start with Dr. Sajal Day. Given the lack of a clear etiology in this particular case, what is the most likely underlying cause of this unusual clinical situation? What do you think? What should be the most likely cause in this particular case? Or you think that there may be more than one etiology? Dr. Sajal, you are mute. Yeah.
Yes. As per the clinical history, it appears the patient is a female patient and CTD profiles is positive. So SLA related chylothorax is one possibility, but she doesn't respond with the treatment. So we have to think about something else is there. There is no CT scan, CT scan of the patient because lymphangiomyoma, LAM can be possibilities, but there is no CT scan of the patients. Lung window is not there.
Dr. Ritin, anything you want to add?
Sir, the CT was fairly normal.
HRCT was normal. There was no cystic changes in the lung.
Okay. And this last X-ray was taken how many days after the starting ATT?
Actually, we started AKT, but patient did not tolerate much. Okay. She was also constantly vomiting and she had, so we have to stop in between anti-TB treatment. And so this is going on almost last 3 weeks now, 3 to 4 weeks, you can say. And the current picture is taken around 5 days or 6 days back.
There is no history of TB in the past, and the patient's 12-plate report also does not suggest any evidence of tuberculosis.
Yeah.
So it is just basically starting the empirical TB, ATT.
Correct. There was nothing in our hand, and we were just, patient was not willing to take even steroids at all. So
yes,
she has received plenty of steroids for almost 1.5 months. So the strictly diet, she followed very strictly this time diet. So the only thing which we could, and before that she was not following diet. That's the only difference. So currently she was strictly under a dietitian nutritionist and she followed diet very strictly, and probably that is the reason probably the recent 2 taps didn't show any chylomicrons and triglyceride levels. They're normal, but still that lymphocytic exudative pleural effusion exists.
In that cases, we can go for fluorodesis to reduce the chance of recurrence. That is the important thing. ATT may not be much helpful because already you have given the diet therapy that has been responding the patient. For prevention of the recurrence, we can go for fluorodesis. That I think so.
Anything else, steroids or any further thing you would like to do? No, you don't want to consider steroids?
Steroid is not indicated in because it is already the patient received the immunosuppressive therapies and not responded with the treatment, and the ligation of the child that already done, surgical intervention is already completed and responded with the diet therapy. So we can reduce the pleural space by obliteration by fluorodesis. That can be the one options in these patients.
Okay. I think we move on to the next question to Dr. Ravi. What further investigations, if any, could be considered to find out the root cause of this particular case? What is your take on it, Ravi? How you would further manage this patient?
Sir, one thing, a very nice case, Prabhu Desai, sir. One very striking feature of this case was that it has a unilateral chylothorax all along. And one more thing was that lymphatic scintigraphy which was done, it did not show any take up. Now that is very strange, sir. Actually, matlab, I strongly feel that since there is a unilateral involvement, there still could be some obstruction or some pathology in the drainage part which we might be missing. So I don't know. Maybe again a reevaluation of the lymphatic system by doing some sort of a nuclear scan, or at least do a whole body PET scan of this thing. And even the right sided, I believe the biopsies which were taken were told to be from the left pleura, which came to be fibrofatty. Maybe some right sided medical thoracoscopy simple should be done once for the local examination of the pleura. Now, only these two things, best everything has been practically done.
So we still don't have an answer. So we are still struggling with the diagnosis, but I think that's the best way we can manage this situation. Coming to Dr. Vishweshwaran. Vishweshwaran, what is your thought about why there is a disconnect between the right-sided chylous leak and the left-sided lymphocytic effusion? Is this one process, or there are two processes simultaneously going out? Is there a single diagnosis or more than one diagnosis? What do you think?
Good evening, sir. And I think when the case is with Dr. Prabhudesa, sir, I don't think any further workup is per se needed. He is the best possible person. But one or two things, sir, as you rightly asked, like the right is the chylus and the left is the exudative. This we sometimes call it as the chylus contrani. Generally, in malignancies, what happens is on one side you get a hemorrhagic effusion, whereas because of the obstruction of the lymphatics on the other side, you get a chylothorax. This is a very rare phenomenon, but even we had one case of chylus contrani, but that was in a proven malignancy status. So whenever we have a chylus contrani, it doesn't mean that there are always two etiologies. It can be one etiology which is causing a unilateral obstruction, which is causing the backflow of the chyle into that particular site, whereas the other part can be the involvement of the disease process itself. In this case, one or two things which I feel can be tried, because almost everything has been tried from the team. The only thing is PET definitely will have a role in this, especially when you have some sort of a discrepancy in the pleural effusion. Let's say when both are chyle, we can understand, but in one side you are having an exudative lymphocytic and on the other side you are having a chylus, then PET can be done to rule out any sort of an occult malignancy. If
they have already done PET. They have already done
PET was done.
PET was already done.
So if that is also negative, then what we had one such case, sir, even now we have that patient with us. So basically what happens is sometimes there can be a congenital lymphatic abnormality, in the sense like these don't present with classical thoracic duct abnormality or something, but they have leaky lymphatic capillaries. So that will be a very diffuse phenomenon. So unlike the classical thing where we see like a particular site of a leak, when you do a lymphangiography for these patients, because of the lymphangiectasiasis, there can be multiple diffuse small leaks which can actually be not picked up conclusively with the help of a lymphangiogram. So
why this type of patient will present so late at this age?
So this age is little unusual. In her case, it is more into the middle age, but generally most of these patients present in the when they are in the adolescence or somewhere around that time. That is what our experience is. Since we don't have a diagnosis, we are thinking about these abnormal situations. So because we are, even the SLE component is not like particularly straightforward, and tuberculosis is more like empirical. So then only in that cases we are thinking in terms of unusual complications like these sort of congenital abnormalities, which can still manifest at a later age for unknown reasons. So in those cases, what we observed is none of the, even in our current case, we have done lymphangiography, we are not able to identify that particular exact site. Then they also tried to do the embolization, but that also didn't relieve. The only thing that to a certain extent relieved the lymphatic recurrent accumulation was the octreotide infusion. We tried octreotide infusion. Along with that, we tried medium chain fatty acids. And sometimes there are very few case reports of certain vasoconstrictors like midodrine or something. But in our case, we didn't use it. But that also could have been tried in certain conditions. But apart from that, what they can do in certain conditions is they can do this ablation of the cisterna chyli, like they can just go and ablate this. They have tried in few cases, but in our case we couldn't try it. So essentially, when we in this sort of recurrent chylous effusion, we have to consider, if we have ruled out all the potential conditions, like as we have done in this case, it can still be a late manifestation of a congenital lymphangiectasia sort of phenomenon. And another thing is, how do we go about in this case? The only thing is, two things can be tried, though they are experimental, like might not be the best case scenario, because we have exhausted the surgical as well as the interventional radiological approaches. Is one, you can try pleurodesis, but pleurodesis generally fails because of the smooth, non-inflamed nature of the pleura in most of these cases of chylothorax. Or you can try an indwelling pleural catheter for a symptomatic relief and expecting the pleural apposition to happen, but there is always an element of risk of infection also in that case. So apart from that, I feel mostly it will be like a medical with an octreotide, as well as we have to give this medium chain fatty acids and nutritional supplementation. But I think it is a very nightmare situation for most of us here. Everybody in there, especially if you are working in a referral center, you get to see such one odd case where you'll not be able to pick up that particular diagnosis.
Okay, thank you. So we have only very limited options in this particular case. Just one query to all the panelists. Would you consider giving anti-TB treatment in this patient, or you would not?
So, sir, can I can
please.
I have my comment?
Yeah,
So, we had two of such similar cases in our setup. Not very common, but last case we have managed about 3 years back. The only difference, the surgical aspect, as far as it's concerned, I think the rest of the medical aspects is discussed excellently. The surgical aspect is concerned, my approach for this case would be slightly different from what it was performed. So number one is I would have done along with the thoracic duct ligation, I would have done pleurodesis on the table on the right side and left side both. Maybe in a simultaneous situation where the right followed by left, or maybe sequentially. The last two cases that I was mentioning, we have done right-sided thoracic ligation and right-sided pleurodesis in one sitting. After 3 to 4 days of the initial recovery, we went the opposite side and did the surgery on the opposite side and did the pleurodesis on the opposite side, with which probably the future recurrences of the infusions will significantly decrease, and in the both cases we actually succeeded. So my approach would be, in this case, I would add pleurodesis on the both sides in this case.
But usually in chylothorax surgery, do they do pleurodesis? Like whatever I have seen in the past, whenever they do surgery for chylothorax, most of the surgeons don't do pleurodesis as a routine.
It depends on the etiology of the chylothorax, sir. If we are talking about iatrogenic chylothoraces, like you would have done some mesophagectomy and then, so in those cases it's not required. This case especially started with an effusion, which complicated to a chylothorax. So these are the cases we have to add surgical pleurodesis in addition to the thoracic ligation.
Okay.
And we have the recent technology of indocyanine green, ICG we call. We can actually visualize the whole of the thoracic duct during the surgery. Usually it's a very transparent kind of structure. It's ligated blindly. But we have the ICG technique where intraoperatively we can visualize the whole of the course of the duct and we can ligate it.
Okay.
So which will decrease the possibility of surgical failures, as happened in this case, where later you have to do the thoracic embolization.
I think you are correct, because thoracic duct ligation surgery is very challenging. It's not not many surgeons know it well. And to localize the site of leak and ligating it is not so easy. And I think sometimes we even do something like, for example, we get a lot of cream to these patients and intraoperatively we see where the site of leak is. That's what we have done in the past. So
yeah, that was history, sir. Nowadays people are more of using the ICG techniques, ICG technique to visualize, because you will see that green color thoracic duct traveling along the esophagus.
And you see the leak also? You see the leak?
Absolutely, sir. Absolutely, will see the leak.
Okay. Thank you.
But if the dye was not ascended in this kind of patient.
Sir, I won't be able to comment why the dye actually hasn't. If the dye is not coming up, then the patient should not have developed chylothorax. So that probably the aberration is in the test rather than the normal anatomical pathway. So there must be some pathway from which the chyle must be ascending to the left side. So in the ICG, what we do is we inject it in the web spaces and in the lymph nodes in the groin. So we wait for at least 1.5 to 2 hours till the time the chyle actually reaches the thoracic duct and drains into the left brachiocephalic vein here. So I think that it's more of a test aberration rather than anatomical aberration. That's what I feel.
Yeah.
But now there is
Mohan, I
no.
just want, sir, 1 minute. Mohan, I just wanted to know, when you talk about pleurodesis on the table, you're talking
Yeah.
about chemical pleurodesis or you're talking about mechanical aberration?
So it would be a combination of mechanical aberration and pleurectomy. So the advantages with this is that the chest wall, I mean the parietal pleura, that is over the costal kind of parietal pleura, we can use that as a biopsy so that we can get what is actually why this effusion has happened. That will win. Whereas in over the diaphragm and all those places, you won't be able to actually remove the pleura from those surfaces. Where we can use the abrasion. Abrasion will help from the pleurosis.
Okay.
And we'll repeat the same on the left side. So we should never leave such effusions turn into chylothoraces. We should always do the pleurodesis on the table.
Okay. That's interesting. I think now with this comment, let us move on to the next question of today. This is to Dr. Ravi Doshi. Ravi, what are the most common causes of chylothorax? Again, an important question for the PG students who are watching this webinar, this MDT. What are the most common causes and how do you investigate a case of chylothorax? What's your approach, Dr. Ravi?
Sir, there can be trauma is one important reason of chylothorax developing. Then you have malignancies which can cause direct obstruction and involvement of the thoracic duct and causing this chylothorax because of lack of drainage. These two things are there, sir, which come to my mind directly. And after evaluation, basically we after your contrast CT scan, you evaluate the whole chest. Once you diagnose it with a chylothorax, so you can go in for these nuclear scans like lymphoscintigraphy is there, sir. You can understand the lymphatic pathways and rule out if any leak is there, and accordingly you can go ahead and manage this. Yes.
Any of the panelists would like to add something to it? Dr. Richa, anything you want to say?
No, not really. I just wanted to ask the difference between the lymphangiography and the scintigraphy.
Sorry?
The difference between the lymphangiography and lymphoscintigraphy. I understand scintigraphy is done by the nuclear medicine
By the
department.
nuclear medicine.
They are two different things.
Scintigraphy is done by the radiologist IR in our this thing. How does both is different in a way to identify?
The thing is, when you do a lymphangiography, you put it dye at the web at the foot, and then the dye traverses up, and then you do it. And that is the other one is the nuclear medicine stuff. I think they use radioactive stuff, and then they do it. So probably they are two different things. They're not the same. You say that's the same? Or?
No. I'm asking which is better in a way. Which is better?
We had the discussion with our nuclear medicine head, and he has told us that the scintigraphy is preferred because it's a radionucleotide dye. The problem with the lymphangiography is that even if the dye or the substance we are using it to delineate the lymphatics, if it is leaking into the pleura, you would not be able to differentiate the leak, the substance that is leaking into from the already existing effusions. Whereas if you use the nucleotide to delineate these lymphatics, you will be able to differentiate the tracer leaking into the already existing effusion. So you will know the path it is taking. In fact, there was a rare case where where they described when the inguinal lymphatics were cut off, there were some collaterals via the abdomen into the pleura. and the dye started leaking via the lateral wall of the thorax into the pleura. So in that way, I think it would be better.
And if suppose in this case, if there is now no chylothorax, then scintigraphy will not be useful at all.
Yeah.
So, sir, can I comment?
Yes.
So basically, this lymphangiography, the usual technique is they inject the dye usually in the web space.
Webs.
Usually, most common
Yeah.
in the web space. But if such technique fails to show the lymphatic channels within the abdomen and the chest, there is a technique of cannulating the cisterna chyli. It is done in very specific centers where transabdominally they cannulate the cisterna chyli, and then from directly in the cisterna chyli they give the dye and they visualize the whole of the thoracic duct. It happened with us in many of the cases where we failed surgically, or if there is an aberration of thoracic duct, even though you clip the one thoracic duct, the chylothorax persists to happen. So in those cases, with our IR people, IR help, they cannulate the cisterna chyli and they can visualize the whole of the thoracic duct anatomy. So this is
Yeah, we have tried a couple of times. It has happened that there are multiple leaks. So if you are able to close one, then you can leak from the other
multiple
side.
leaks is a rarity, sir. Multiple leaks is a very rare situation. Especially what about 35-40 cases we have managed. More of the situations, it is a single site of leak, which leads to recurrent issues.
Okay.
Okay, just for all the panelists, I just wanted to ask if you are not able to identify the cause for chylothorax, and we assume it is idiopathic after doing extensive workup, everything, what is the right, management? Do we do the ligation of the duct without knowing even that, it is the leak is there, or we do a surgical pleurodesis?
Can I answer?
Yes, please.
Idiopathic, that everything depends on the amount of the chyle that is the patient is draining, first of all.
Yeah.
So our decision depends on that. Not every patient of chylothorax requires thoracic duct ligation. We have a publication even on chylothorax which actually classified the everyday drainage of the chylothorax, and based on which we took the decisions and the outcomes. There is a very good paper, ma'am, in Lung India we have published it. What it says is that if the drainage is less than 150 to 200 ml per day and the patient, the chylous drainage is decreasing with the conservative therapy. So what we do in our unit is, once the patient has chylothorax, first thing what we do is keep the patient on MCT diet, give octreotide, and at least wait for 5 to 7 days for the therapy, the response to come. If the chylous leak is increasing, and if the even with the first instance every day 500 ml plus chyle is coming, in those situations we will directly go for thoracic duct ligation. Earlier, we used to go to thoracic ligation without lymphangiography. Blindly, we used to go there. But we have one or two cases of failures because of many anatomical factors rather than surgical factors, because there are the direction of the duct is somewhere else. You have two ducts actually. So those aberrations were there. So that's why we always do lymphangiography before going for a surgery in all these cases.
Yeah.
So everything depends on how much of drainage the patient is having per day.
Yes, I agree, because we had last case which we had, that also that patient didn't require any surgical intervention, was managed with diet and octreotide. And that patient is a known case of malignancy. That patient responded to it, but it took about 2 weeks time to respond. So there are patients who respond to non-surgical management. Only subset of patients who don't respond may require surgical intervention.
Yes.
I think we end this first case and then we move on to the second case of today. This case will be presented by Dr. Rishabh Ranjan Singh. He is a DNB second year resident from the Department of Pulmonology at Ramakrishna Care Hospital, Raipur. Rishabh.
Good evening to all the respected panelists. I think I'm more privileged that I'm presenting this case in front of you. I'm going to present a case of a leukemic pleural effusion, a rare presentation of acute lymphoblastic leukemia. Basically, a patient of 25-year-old male with low socioeconomic status presented to us in our OPD with chief complaints of SOB, decreased appetite, weight loss since last 2 months. He was not having any comorbidities, and during our general examination, we found that everything was normal. The respiratory system examination, there was a dull note with decreased intensity of breath sounds in the right infrascapular region, infraaxillary and inframammary area. On routine investigations, we tend to find that the patient was having leukocytosis with a TLC count ranging around 80,000, thrombocytopenia with platelet counts of around 61,000. His RFT-LFT was normal, and his peripheral smear examination was suggestive of acute leukemia. We did an X-ray, and in the X-ray we found that there was a right side homogeneous opacity, which we did ultrasound also, which found to be right-sided moderate pleural effusion. Following which we did a CT scan in which we found that the patient was having moderate right side pleural effusion with basal collapse of right side with no mediastinal lymphadenopathy and no parenchymal abnormalities. After that, we did a USG guided pleural tapping, and we aspirated around 550 ml of red turbid colored pleural fluid, which we sent with for the investigations. The pleural fluid report analysis showed that the patient was having exudative lymphocytic effusion with AD of around 58 and LDH of around 324. The WBC count was around 5,000, and the patient was having mononuclear cells, 60% mononuclear cells, 30% lymphocytes, and 10% polymorphs. The gene expert was negative. In the pleural fluid cytology, as we can see in this pleural fluid cytology, the cytologist just examined in that, and then we found that the patient was having the blast cells with the two large nucleoli, as we can see in this blast cells, with the cytoplasmic granules in the periphery region, which they interpreted as that there some kind of pleural involvement due to some atypical cells. We did a bone marrow examination, and we came to a diagnosis that the patient was having T-cell acute lymphoblastic leukemia. After that, we consulted with the hematologist, and he advice for the leukemic diagnostic panel. As we can see in the leukemic diagnostic panel, that the patient was further diagnosed to have the early T-cell precursor lymphoblastic leukemia, and due to that, the pleural cavity was involved, which which we have seen in the previous slide, that the patient was having this. As in this slide, that the predominant nuclei with all the involvement due to the atypical cells. We held a multidisciplinary discussion with the pulmonologist, hematologist, radiologist, and the cytologist, and we came to a final diagnosis that the patient was having T-cell acute lymphoblastic leukemia with leukemic pleural effusion. We referred the patient to the hematologist, and he was started on chemotherapy for T-cell acute lymphoblastic leukemia. After 1 month of induction chemotherapy, response assessment was done, and the hematologist used a criteria that is known as a minimal residual disease, in which there are a few cancer cells which can be remnant, which can be present even after the induction therapy. That if it is less than 0.01, then the patient is considered that the therapy is successful, and the patient can be considered as a remission stage. The patient is currently in the remission stage and is asymptomatic, and he is going for the consolidation phase therapy.
Thank you, Rishabh.
Yes.
Thanks, Rishabh, for this nice and rare case. I would like to ask Dr. Sajil Day his opinion about the leukemic pleural effusions. We know it is very rare entity, and is cytology enough to diagnose the leukemic pleural effusion? Because even in the cytology, in this we are seeing it is atypical cells. Now, when we say atypical cells, atypical lymphoid cells or mesothelial cells can be misdiagnosed as atypical cells. So what I'm saying is false positive results. So, sir, in your opinion, what is the diagnostic value of cytology or flow cytometry or molecular testing in confirming leukemic infiltration in pleural fluid?
Thank Thank you.
Your insight on that, sir.
Basically, this case is straightforward because his peripheral blood smear already shows high PLC count. So acute leukemia is suspected. And after doing that, when the pleural fluid is examined, the atypical cell does not mean that it is always a malignancy because long-standing effusion can give rise to atypia. And in this cases, the lymphoblastic cells are seen in the pleural fluid. So I think it is a straightforward, appears to be the T-cell lymphoma. It is not a TB because the ADA is so high, but ADA can be positive because of the malignancies.
So do you consider that, pleural biopsy is not required, or we could have done more immunoprofiling on the cytology? Or we could just take it this case as leukemic effusion?
Already diagnosed with the ALL, in that cases, there is no need to do pleural biopsy, but we can go the cytological profile of the pleural fluid can be done. Other than this, there is no need to go for the pleural biopsy in these cases.
Just to interrupt, we had a discussion with our hematologist and our cytologist. Both of them were very confident about the diagnosis. They said there's no need to, we had a detailed discussion between our panel of consultants, and then we decided that because this is straightforward, so we didn't went ahead with any further investigation. The patient was not so affording. We didn't wanted to add the cost to, and management would have not changed much because we didn't have any other differentials at that point of time. So we decided, and patient responded very well, and that was the reason why we didn't went ahead for the further investigation.
Visves, how would you feel clinically? Because effusions can be there, pleural effusion can be because of this, leukemic pleural effusion from effusions due to infection or malignancy or drug reaction. Clinically, is there any way we can distinguish?
Clinically, it is very difficult to diagnose any infection, but there is an acute history, and from the blood test, we are able to get the patient has an acute leukemia.
Visves, your thoughts on it?
We had a very, very interesting case, ma'am. So one case, we had it as patient presented to us with more like a lupus cell in the pleural fluid. Mm-hmm. And they wanted to actually pulse the patient with steroids. Then somehow we felt that the lupus generally don't tend to present as unilateral. We expect a polycerocytis, but it was more of unilateral. We went ahead with a thoracoscopy and biopsy. We got a coexistent tuberculosis on the same site. So lupus pleuritis with the tubercular effusion was there in the same site. So dual pathology is not uncommon, especially when you're dealing with a TB endemic country like India. So in this case, I wouldn't say it is wrong, like it was the appropriate approach considering the socioeconomic and the financial status of the patient that they didn't go for a pleural biopsy. But had this patient not responded to the way that the patient has to respond to the chemotherapy, then definitely a coexistent infective etiology like a tuberculosis should be in the back of the mind, because again, it's an immunocompromised state, and still you can still have a tubercular effusion with a leukemic effusion. But it is not like upfront you need to go for a thoracoscopy and a biopsy. You can look for response to treatment, but we should not be steadfast that it is only a leukemic effusion, because two diseases can still coexist.
Ravi, when it comes to the treatment for these patients, lymphomas, like we know now, we usually wait for the chemotherapy. So if this patient, especially this patient, has a moderate effusion and you can still wait, but if there is a large effusion, patient is symptomatic, do you think that leukemic large pleural effusion warrants pleurodesis, or we can wait for the chemotherapy with just therapeutic aspiration for symptomatic relief?
Ma'am, it all depends, I feel, on what is the respiratory status of the patient and how well he's coping up with the
symptomatic patient.
If the patient is symptomatic, definitely, ma'am, we first of all need to put in an intercostal tube, drain as much fluid as possible. And if we are having a history of a recurrent fill-up, then we need to discuss with our hematology colleague regarding the pleurodesis. Now, there is one thing also, ma'am, that sometimes in these blood hematopoietic malignancies, you can even get some amount of paramalignant effusion. It is not always that it is malignant only, but oncologists, and whenever in leukemia they have pleural effusions, then they just tell that you leave it, our chemotherapy will take care of it. But I see patients who suffer quite a lot, they are in quite a lot of distress. So I am more of, if it is a means we should evaluate the fluid, and if there is significant recollection that we are seeing, then we can offer fluoridesis to these patients. There is no harm.
So what's the experience of all the panelists, if I would ask, in patients? Leukemia, I haven't seen any patient with leukemic pleural effusion, but lymphoma, yes, many do come. So initially, in patients with recurrent effusions, we did recurrent lymph effusion, we did try, pleurodesis, but invariably it failed. And then when they respond to chemotherapy, they do really well. So henceforth, we have decided that the patient is symptomatic. We just do the therapeutic aspiration as many times required. Or now that you can put up a this thing IPC also for controlled drainage, whatever patient wants. And most of the time, if they have to respond, they respond to chemo. Should be. I'm just kind of asking everyone, each panelist, to now put in your thoughts. I put mine.
Ma'am, I would just like to share one of my experiences with the case of multiple myeloma, ma'am. Multiple myeloma, they have effusions pretty late relatively. And when they have effusions, they tend to enter a refractory phase of the disease. So that is when, even the oncologist has given his chemotherapy cycles 10 or 12 times, and he is also quite at a situation where nothing is working. You do whatever you want to do. But I have seen, if you pleurodise these patients, at least you can give them some sensible quality of life, although for short spans, but it does work for a short period of time.
I think sometimes pleurodesis does work, especially when you have a recurrent effusion. You give chemo, and if there is still a recurrent pleural effusion, you are requiring tapping multiple times, then we have gone and did pleurodesis, and it works in quite a few patients, if not all. So, and couple of times what we did, we have to do pleurodesis twice also. We have done pleurodesis more than once. The first time it failed, we attempted after a few days, again we attempted, and that worked. So there are situations when you may have to go ahead and do a pleurodesis more than once. Occasional situation that is, and that is the second time it worked. So if the patient, we don't have choices, then yes, we have to go ahead and do a pleurodesis. But as far as this patient is concerned, because the patient is clinically responding, there is no refilling of pleural effusion, so we are waiting. In case if it refills again, then maybe we have to consider for maybe pleurodesis, or even reassessing the diagnosis. So in case there is a refilling of pleural effusion, so that would do.
In our practice, we uncommonly see such kind of leukemia and all those related effusions. What we see are more of lung cancer, metastatic lung cancers, or distant tumors which metastasize to the pleura and leading to recurrent effusions. There is one factor which will definitely say the success of a pleurodesis is the amount of drainage per day in that patient. So what we see in observation is that if the amount of 24-hour drainage is more than 500 ml, the pleurodesis is going to fail, irrespective you are doing you are putting blindly through the tube, or doing medical thoracoscopy and putting tall pleurodesis, or if you take the patient to the OT and under vision you do the pleurodesis. If the drainage is more than 500 ml, these patients are going to fail irrespective. So probably these are the situations when these fail, then indwelling catheter is one possibility. So we do get lots of these.
We do pleurodesis only when there is about 100 or 150 ml per day drainage, and we don't do pleurodesis if there is a large drainage, then we may not do it because that doesn't work. So usually we wait till the time
the all the powder that you put actually gets washed out in next 1 hour. So no possibility of anything.
Mohan, I would differ with you in this, because we don't wait after putting a chest tube or post thoracoscopy. We don't wait for the fluid to come down to 100 or 150 ml. For us, the lung expansion, no leak, is the time to do a pleurodesis. Invariably, whatever is the amount. I understand that there has been thoughts about, if there is some says more than a liter, some says more than 600 ml per day, it is likely to be failure. But our observation, again, we don't have a paper at the moment right away, but our observation is that somebody who has to fail can fail even with small effusion. And I mean, we do get successful pleurodesis. So
what we do is that we have to see complete lung expansion. That is very important. If the lung is expanded well and is both the pleural surfaces are abutting, and second is we wait for the drain. That's what our standard teaching has been there. That we wait till
we
the
don't
time.
wait actually for that now, sir.
So,
We
but
just pleurodese
but the
that.
thing is, we don't have any evidence that what exactly would be like what is the cutoff.
Right. To answer that, we are just going to publish a paper where we have. But again, that is against early pleurodesis versus late, but it kind of answers the question because pleurodesis was done invariably whatever is the drain, and we are going to publish the paper soon, sir. It's an RCT.
Okay.
Okay, so Sajal sir, I wanted to ask you about patients on lymphoma, leukemia. They may be getting treatment with TKIs, and we know some of the TKIs are nuisance to cause pleural effusion. So, if a patient develops new onset pleural effusion who is on TKI, what would be your diagnostic algorithm?
In that cases, we have to look for the alternative diagnosis also, because TKI just doesn't give all the cases with the reappearance of the effusions. If the patient is not responding, then we have to look for the biopsy also, as discussed by the previous panelist. And TKI is basically diagnosis by exclusion. If we do go for the biopsy, if the biopsy is inconclusive, then we can think about maybe TKI related, but we cannot pinpoint the diagnosis by the investigation alone.
Right. So I think the message is very, very clear that if the patient on TKI develops pleural effusion, it is a diagnosis of exclusion. We should not, because these patients are immunosuppressed, and we live in TB endemic countries, so we have to rule out other possible etiologies or infections, and once so pleural biopsy is certainly required, imaging is required, all sort of imaging, maybe medical thoracoscopy probably, and once you have ruled out every other cause, then probably you could say it could be TKI related, and in that case you stop the TKI, change to another TKI, and some of these patients may require a short course of steroid, and some patients do not require. So over to you, Visweswaran. Coming to these effusions related to these patients, lymphomas or leukemia, how should a clinician would balance between the infection control and pleural drainage in patients who are immunocompromised?
So I think we are dealing with a malignant pleural effusion, ma'am. So when it comes to malignant,
No, Visweswaran, I'm talking specifically about leukemic pleural.
so yeah, that's what. So here the algorithm remains essentially the same that what we follow for malignant pleural effusion. It is not like something separately we have an immunocompromised condition. So in this case, the dictum is very clear. First, we see the survival of the patient. If the expected survival is going to be very, very less, he is going to be extremely terminally ill, like that is going to be like few days or something, then definitely we wouldn't subject this patient to any sort of pleurodesis. In most of the cases, that's what the guideline says. It's going to be primarily a palliative sort of thing, more like drainage. But if the survival is going to be good enough, like at least more than a month or so, and the patient is having a recurrent effusion, first you are going to see whether he is going to have a trapped lung or he is having a fully expanded lung. So if it is going to be a trapped lung, the dictum is quite clear. You put an indwelling pleural catheter and then you leave it and allow the lung to expand and do frequent drainage to enhance the success of pleurodesis. Whereas if you have a fully expanded lung, the guidelines are moving more towards putting an IPC along with a talc, which is the IPC plus study. Like you put both the talc and the IPC, which will increase your chance of a pleurodesis. Having said that, in a country like India, where economic constraints are going to be there, this becomes a decision of not only the guideline based. It is also going to be the decision of the financial and the social factors. So what we do at our center is, like, people who can afford an IPC, we are moving more towards an IPC. In fact, if we really consider the cost, it is actually less. Though we feel like it is a more expensive affair. If you see in a working in a corporate like setting, rather than putting the patient on a talc and then asking them to give wait in the emergencies, and sometimes these patients have severe pain where they go in for an admission, and after that we remove the ICD after 2 or 3 days. We generally put the IPC, and nowadays Indian made IPCs are available, which is quite cheaper in comparison to the Plurex or the other rockets which we are available earlier. Now Indian based IPCs are there, which comes at half the cost of these Western IPCs and functions essentially the same. So you put an IPC, you discharge the patient the very same time. So that is, so if cost is going to be the constraint, yes, in government settings where there is more access to, where the patient cannot procure it, still we go for upfront fluoridesis. Whereas here the choice is between either an IPC or a slurry. I would still incline towards an IPC. And sometimes if the patient, where we feel like despite IPC, if the patient is not improving, recurrent fluids are coming. If the lung is, we drain out the entire fluid and we add talc to this IPC also to increase the rate of fluoridesis. So this is what we have been following. I think the acceptance of IPC is increasing day by day. And there are cases, as we saw in the earlier case, like refractory benign effusions. There are cases like that. For example, patient is having a severe sort of refractory heart failure with recurrent effusions forming, and you get repeated calls from the cardiologist. In sometimes even in hepatic hydrothorax, for that matter, these are like extended indications of IPCs are also being practiced in desperate situations.
I think I agree. We have kind of covered all the aspects in terms of
Should we move on to
diagnostic.
the third case?
Yeah, the
I
message
think
is very clear from this that in an TB endemic country, though there can be a dual pathology. So if the patient is not responding, act early and probably look for the other etiology as well. Over to you, sir.
Ma'am, you forgot about the surgery.
I forgot about the surgery.
So just make a comment before, because we have managed about 5 cases in the last 2 years, especially after the TKI, that is the dasatinib, used for chronic myeloid leukemia. We had patients with recurrent effusions which actually got complicated. Usually the effusions goes to the pulmonologist. If they get complicated with, then they comes to us. So we have done 5 selected
Mohan
cases.
sir, sorry to interrupt. It's the other way around also. When a surgeon gets stuck with a BPF, they send it to us. So it's always mutual.
Absolutely. It's all a team game. It's not like one is superior to other. So this is the one surgical experience that I want to share. So if the complicated pleural effusion, especially in such kind of cases, especially dasatinib, so surgery can help in selected cases for sure.
only when it get complicated because of infection or multiple adhesion septations, then maybe that may be a situation.
Absolutely. Yes.
Thank you. I think we move on to our next case. I invite Dr. Pradeep Jain, Senior Consultant Pulmonologist from Chowdhury Hospital, Indore, to please present his case. Dr. Pradeep.
Sir.
This is the last day or case of today. Interesting and something very uncommonly seen.
Yeah. So, good evening, everybody.
Can you make it full screen, Pradeep?
Sir, at my desktop, it is appearing full screen only. It's not there as a full screen.
I think
I will reshare it. Pardon? I'm not able to see.
Yeah, top right.
Right.
The yellow column, sir. The yellow column which you see on the
Okay.
third, enable
Click
editing.
on the enable
Okay,
editing. Yeah.
okay.
Why you are doing that?
Okay.
Ah,
Now,
yes.
okay. So, good evening, everybody. I'm not going to take much time because after an exhaustive discussion, you are draining out. This is a case, a 52-year-old male. He came with a complaint of cough, breathing difficulty, loss of appetite, and loss of weight with a total duration of 20 days. And there was no addiction, no past history of significant illness. The patient was an engineer by occupation. So initially on chest examination, the air entry was reduced. So we have done a chest X-ray in which was consistent with our diagnosis. The X-ray shows an opaque left hemithorax. In this case, we proceeded in a typical textbook manner. A diagnosis of tentative of pleural effusion was made and therapeutic taping was done on an OPD basis. And in that, we have drained 750 ml of pleural fluid, which was hemorrhagic. The protein was 4.7, glucose 134, total WBC was 2500, and the neutrophil was 60 and lymphocyte was 40 with innumerable RBC. Fluid AD was only 11. AFB smear, the AFB was not detected. Cytology and cell block was also sent in the same sample, and it was also turned out to be negative. Subsequently, patient was advised as he was having a mediclaim, so he is told to everything to be done on a mediclaim basis. So we admitted the patient, and this is a CT which has been done. In this, you can see atelectatic collapsed lung and a well circumscribed mass lesion with significant amount of pleural effusion. So we planned a thoracoscopy in this patient. This is a lung window. The right lung is virtually normal, and the left lung, you can see it's completely opaque. And so we performed a medical thoracoscopy, and this is a thoracoscopy video. Hemorrhagic pleural fluid with a unhealthy parietal pleura, as well as a large nodule which is present on the diaphragmatic pleura. So we took multiple biopsies from variable site. In a cell block, we don't got anything. In pleural fluid biopsies, they were suspicious of carcinoma, but they are not able to make a typical diagnosis that what actually the tumor is. This was the largest nodule which we found, and rest of the parietal pleural lesions were basically unhealthy mucosal one. So we took a multiple punch biopsies, even the deeper cuts. And since we don't got the diagnosis, so USG was done, and the USG shows again the lung mass, which was not having any conclusion. So they advised to go for an immunohistochemistry. And in immunohistochemistry, it turned out to be a monophasic synovial sarcoma of lung. The purpose of presentation in this case is that we followed the textbook protocol initially of tapping and a cell block, which was negative, a medical thoracoscopy, which shows a suspicious of carcinoma, then a USG guided true cut biopsy, which was suspicious of malignancy. Again, no confirmatory answer was yet, and it's only an IHC, which turned out to be a definitive diagnosis, and it was basically a googly for us because we were not suspecting something like this. So even my oncologist, when he received the IHC, he told her googly ho gayi, and we got the diagnosis of primary synovial sarcoma. Till the time I have not read anything about it. So when we go back and read about this entity, I come to know that this is one of the entity which can present in this manner. And this is the recent X-ray when the patient came to OPD. He was having chemo port in situ, and he has received some cycles of chemotherapy, and he is responding. Patient was also advised for a bronchoscopy when we are having a dilemma of diagnosis, but the patient was quite apprehensive for going for a biopsy, bronchoscopy. So bronchoscopy was not done in this case. This is a PET scan image of this patient. And the PET scan shows a gross uptake in the mediastinum as well as the well circumscribed lesion which we have found in the CT scan, which show quite significant uptake. And only from this particular reason we have taken the biopsy and we come to the diagnosis. So a synovial sarcoma are the rare mesenchymal tumor which account for 10% of all soft tissue sarcoma, and the synovial sarcoma of lung is a very rare tumor which account for less than 0.5% of all primary lung malignancy, and the most appropriate management is surgical excision, particularly when case where there is a negative margin. Adjuvant chemotherapy and radiotherapy has a limited role and they have got a high rate of recurrence. So this is just about an interesting case which I felt that it should be presented to the house, and since it's an MDT based on the pleura only, and the presentation in this case was from the pleural effusion. So this was my purpose for presenting this case. Thank you, sir.
Thank you, Dr. Jain, for presenting this rare case. I think I'll take up the questions, maybe what I had in mind to anyone, all the panelists. How often do you see or have you seen primary pulmonary synovial sarcoma in your practice? I haven't seen any. I've seen, metastasis, but not the primary. Yes, Viswes.
Ma'am, I think some of you are either unlucky or lucky. We have seen, and unfortunately, you will see many of the young patients having it. Unlike the tumor which occurs in elderly, it is mostly like 20 to 30 years and generally extremely aggressive sort of these tumors. And good thing is, sir, you didn't try a bronchoscopy and biopsy. Sometimes these tumors are highly vascular and they bleed very much. And most of the time, these tumors tend to recur repeatedly, even though you get a good surgical margin. We have seen tumors recurring, and they present in a similar fashion every time the patient comes to you with a massive effusion, and then you may have to drain multiple times, and sometimes fluoridesis may not be effective in many of these tumors as well, and sometimes there is a role of a local site radiation also post surgery. They tend to give these local site radiation. And one another aspect of this synovial sarcoma is they tend to have very high incidence of pneumothorax actually, because they form some sort of a cyst in the lungs, and they come, sometimes these pneumothorax can be we had one such patient who had a pneumothorax. Later it turned out to be a case of a synovial sarcoma of the lung. So we were unlucky or lucky to have these cases. I think probably, I'm not sure about the exact numbers, 2 or 3 cases we have seen. And unfortunately, these are extremely aggressive tumors, extremely vascular tumors, and predominantly affecting 20 to 30 years of age. So sometimes if you get a lymphocytic exudative low ADA in this 20 to 30 age group, 2 things always in the back of your mind: lymphomas and synovial sarcomas. So that is what has been our experience.
We were also thinking of a lymphoma only. It turned out to be a synovial sarcoma on IHC. We were even unhappy with the pathologists that why, despite taking multiple samples from the multiple places, they are not giving a confirmative diagnosis. But at the end of the day, I found that they were right enough.
And even your pleural fluid will almost mimic like not a hemorrhage. It will look like as if a hemothorax actually. If you see the consistency of the pleural fluid in these cases, sometimes you will fear maybe you have traumatized the intercostal artery while putting a drain. It will be more towards a bloody nature. Later in your pathology report, it will come as more like a hemorrhagic.
So, Dr. Jain, did the pathologist run the markers on pleural biopsy also later?
No, ma'am.
No, they didn't,
because it has been done on the true cut biopsy.
Only on the mass only. Okay, okay. Because they were initially they said it is carcinoma, whereas it turned out to be sarcoma. So okay.
Yeah. So to share our experience, ma'am, so out of the 100 the cancers, lung cancers we operate, we do see about 4 to 5 cases of sarcomas, the primary lung sarcomas, where we do surgery, either lobectomy or pneumonectomy. So out of which the most common pathology that we see is the synovial sarcoma, primary lung synovial sarcoma.
Wow.
The other most common is myxoid fibrosarcoma, is that one which we see in another manner. So, since you said this, it's a very interesting. As Dr. Vishweshwaran said, usually the young people recurrence is high, but we know that disease is going to recur. But we give the therapy of surgery to them. Apart from this this sarcoma, I want to share two pathologies which can present with recurrent effusions, especially the hemorrhagic effusions. One thing is called pleural hemangioma. This is one pathology which we have seen in the last 3-4 cases successively, where the patients usually present with serosanguinous kind of effusions, recurrent effusions. So medical thoracoscopy reveals a sessile kind of tumor, usually on the pleural surface, especially on the costal pleura. So where after surgical excision, so surgery is the final definitive option in those cases, where after removal of the tumor, the effusion will come down. The other is the solitary fibrous tumor. So it's basically the tumor of the pleura. Many a times it's a very slow growing and asymptomatic kind of tumor. But in some situations, it can present as hemothorax, spontaneous hemothorax and hemorrhagic effusions. So we had about 5 to 6 cases in the last 2 years with this kind of presentation, apart from the synovial sarcoma.
Mohan, another important, sorry, you want to say something?
No. I was just asking about the solitary fibrous tumor. Usually what we have quite a bit of cases. They usually present with the large tumors occupying almost
Usually
the
they're asymptomatic, very slow growing. Looks,
asymptomatic. And
yeah.
Somewhere they will feel chest heaviness after a long time, and when
Yes.
you see X-rays, completely white out lung.
Yes, absolutely.
Do a CT scan, you found it's a big mass,
Yes,
and
yes.
but they do okay after surgery.
Very well. They are usually benign tumors. They don't recur. And the largest we have removed is about 5.2 kg. That was the largest one we have removed, which is occupying the whole of the chest actually.
That's
So,
big.
but they're benign tumors, they do very pretty well after surgery.
Mohan, the important thing to ask, if this particular case, would you consider surgery in this
Sir,
case?
actually, I was
Yes.
going to ask Dr. Pradeep Jain, but just I want to see the mediastinal cuts of this patient. And just I want to ask him, the biopsy that you have taken is from the diaphragm, not from the mass, right?
Means the last one on which we have performed the immunohistochemistry, it was done directly from the mass lesion.
Okay. So things are too different here. So if we are talking about, there is only the mass, but there is no metastasis to the pleura.
So there is a metastasis possibly. There is a metastasis of pleura.
So if there is a metastasis pleura, there is no lot of surgery. Surgery is not going to help him at all. If the disease is localized to the only one area and it is a reactive effusion rather than a metastatic effusion, then surgery is.
If you have a hemorrhagic effusion in a patient of malignancy, unless proved otherwise, it would be a metastasis. No?
Yeah, I agree, sir. I agree, but there are some aberrations. As I said, this pleural hemangioma, it's not like there are few uncommon cases.
And in your experience, whenever you have operated such cases, how was the outcome? Was the results are good or no?
Sir, for sarcoma, if the only therapy that you can do for the patient is surgery, if it is operable, and because the chemotherapy and radiotherapy are not efficient in sarcomas. Carcinoma is a different ball game, but sarcomas the primary treatment is usually surgeries. However, sarcoma, the rule is there are 3 R's in sarcoma management: recurrence. So anywhere sarcoma, recurrence is the most common problem that we see. So either it is localized or systemic. The best of the surgery you do, the possibility of recurrence is very, very high.
A close follow-up is required in these patients. Very close follow-up. Yeah.
Absolutely.
In a limited experience, I can say that those tumors who are difficult to diagnose on these instances, they always turned out to be something unusual cases only. I remember in one case we have performed a bronchoscopic biopsy, then true-cut biopsy, then again a true-cut biopsy was performed at Bombay Jupiter Hospital, and ultimately when the 4th time the true-cut biopsy was done at TMH, then only we have a diagnosis. It was a NUT midline carcinoma. So means I think 15 core of biopsy and from different places, and only when it has reached to the tertiary care center, and when they thought that why we are not getting a diagnosis, then it turned out to be the rarest of the rare tumor.
Yeah, since Dr. Pradeep sir said about NUT, I think that also we should have in the back of the mind, because we had this NUT carcinoma. These are generally called midline tumors. Extremely aggressive. Again, almost like a similar presentation. If you have a presentation like small cell carcinoma in a non-smoker, 20 to 30 years of age, and you have ruled out lymphoma, nut is something which we have to ask the pathologist, because it requires so much of these IHCs. They go for panel 2, panel 3. Only in the end they come with nut. But the unfortunate problem with the nut is whatever you do, like whatever you do, they won't survive like more than 6 months. Like extremely aggressive, it will invade all the central blood vessels. And we had a patient with a nut cell carcinoma. So
Yeah, they are usually nut cases.
I think more or less we've discussed everything. Anything you want to add, Dr. Richa?
No, I'm floored by the type of cases actually.
Yeah, that's very interesting cases. I think we learned a lot. I think in last 3 MDTs we had all rare and interesting cases, and today also we had all good cases. Any comment from the panelist?
So there is a question from the technical team regarding management of pleural mesothelioma.
Yes, surgeons are going to answer that.
Okay.
So I think so with the advent of chemotherapy and recent immunotherapy, the role of surgery in mesothelioma is actually going down and down and down, because the kind of surgeries, the extent of surgeries that we do for mesothelioma is associated with significant perioperative mortality and morbidity. Primarily, we do two kinds of surgeries for mesothelioma. Mesothelioma, one thing is called EPP, that's called extrapleural pneumonectomy. What it means is we remove the whole of the pleural tumor invading the lung, so we have to remove the whole of the lung. And then the mediastinal pleura, the pericardium, diaphragm, almost it's like you remove almost everything in the chest on the right one side. But most of the patients actually don't tolerate such kind of massive surgeries. Then the concept of minimal surgery came, that is called EPD, that's called extended pleurectomy decortication. What it means is don't remove the lung, keep the lung there, remove only the pleura that is diseased. The concept of surgery in mesothelioma is macroscopic clear resection. It's not microscopic clear resection. So whatever the disease that is visible to you, you remove it, accept that there is going to be a microscopic disease in the chest, and manage that microscopic disease by the adjuvant therapy, either in the chemo or radiotherapy. But there are so many trials that randomized trials which have come in the recent times, which showed that if you don't do surgery, the possibility of patients surviving is much more higher. So more and more surgical teams are actually getting away from operating such kind of tumors, except in patients who are really fit, especially the epithelioid variety of mesothelioma, if the patient is having that. So mesothelioma can be of epithelioid, there is something called sarcomatoid, there is something called mixed varieties something, but surgery is indicated only in epithelioid kind of varieties, where the outcomes are much better, less aggressive disease compared to the sarcomatoid kind of things. So if a patient is fit and if the disease is operable and it's a epithelioid variety, yes, of course we can, and we will attempt for the pleurectomy decortication surgeries where most of the patients actually tolerate it well. So surgery is not only the therapy, now with the chemotherapy, radiotherapy, and even the immunotherapy has actually changing the scenarios in mesothelioma. That's what a brief description about.
Sushil sir?
Yeah.
Sushil sir?
Yes.
Yes, sir, I am not a panelist, but I have got one question. If
Please.
you are allowing me, I want to
Please.
In first case where we have given a therapeutic trial of ATT, considering a chylothorax, in a conventional learning, we can also have that a long-standing pleural diffusion can also present a chylous type of appearance, particularly in tuberculosis. Then differentiating features are just based on the cholesterol level beyond triglyceride. So means why can't it be, since the patient was having effusion since 1 to 2 years and it was a long-standing effusion and ultimately she had shown a good response to ATT only. So if we go beyond and forget about the all fancy thing, why can't we think that it was a chylothorax because of a long-standing nature of the effusion?
The history was not that long. To start with when the patient presented.
Yeah.
And then later the patient had a pleural effusion initially also, no?
Yeah. Initially it was there, but the chylous type of appearance only on the subsequent tapping only.
I would add on, Dr. Pradeep, on this. So basically, presence of cholesterol crystal is what differentiate between pseudochylous and chylous. When you have a triglycerides of more than 110 with the presence of chylomicrons, it is essentially always chylothorax. And that is what they have shown in that also on the left side. So I believe that is true chylothorax.
The chylomicrons with high triglycerides were there in that patient.
Yeah, and Sir Prabhudesai sir actually said that the patient was started on ATT, but she was not tolerating very well. So she was kind of vomiting and all. But what she followed was very strict adherence to the MCTD diet, and he believes that it was that which was the reason for her improvement in the chest X-ray. Just to add on.
Agree, ma'am. Agree.
So I think if there are no other comments from any of the panelists, I would consider this MDT as finishing. But before we say goodbye and a happy weekend to everyone, I would like to thank Sajal Dey sir, Mohan, Pradeep Jain and Visweswaran for being esteemed panelists and for
Ravi.
And Ravi, I'm so sorry, Ravi. I'm extremely sorry. My heartfelt apologies to you. A slip of mine. I'm getting old. So Ravi, the star. Thank you all for joining and actively participating and enlightening us on these three different cases. And we think that pleura mein kya hi hoga, but you see in all these three pleural MDTs, we have seen how different the cases could be, how complicated it could be, and how Mohan can actually help us out in these cases. So my sincere thanks to technical team for all their support, and Cipla for our academic partner, and Sushil sir. And I don't want to thank you because both of us are. So thank you so much.
Just to add on, I think thanks to the two residents who have presented their cases so well, and thanks to Cipla who has helped us to organize this this MDD. And last but not the least, thanks to the audience who have been there with us, and we are trying to make this as good as we can, and with a lot of learning and a lot of mistakes, we are trying to improvise every time, and hope we'll do it better. I think any comment from any of the panelists, or we should wind up now?
It was a fantastic discussion, sir. I mean, the cases that were described, starting from chylothorax to the rare malignancies, the spectrum was fantastic, and the discussions were mind-blowing. I think it will help everyone. I also learned so many things by this discussion, and I am sure everyone has their own learnings from this wonderful webinar. And of course, this will continue more and more. And congratulations, Indian Plural Network, for conducting such a vibrant academic kind of discussion dedicated to the pleura. I think it's one of the kind, and there is a long way to go with the efforts of everyone, and especially Sushil sir and Richa ma'am. And hearty congratulations, sir, for both of you.
Thank you.
IPN rocks, madam pass हो गए इतना बता दो बस.
अरे सर क्या बात कर रहे हो, बिल्कुल 100%, 120 out of 100, and really heartfelt apologies, Ravi, for missing out the name.
Fine, nothing.
Thank you everyone, and have a happy weekend.
Thank you. Good night.
Thank you.